So a very good morning to you, and thank you to everyone for coming out, and thank you very much to We the Patients for inviting me to speak today. My name's Dr. Rowan Thomson. I'm a resident doctor working in the private sector prescribing medical cannabis. I'll probably go into my disclosures. So I work for dispense clinics. As a full disclosure, I'm also director of a company called Eden Bioorganics R&D. We focus on microbial products for cultivation. And I'm currently the vice chair of the Medical Cannabis Clinician Society. So the main focus of what we're going to be talking about today is our endocannabinoid system. This is essentially the system that cannabinoids work on, and I think there's a lot of value in getting a bit of understanding behind that, and learning how we can all take responsibility for our own endocannabinoid health. The focus today is on chronic pain, so naturally we'll be talking a little bit about how the ECS can be targeted for pain management, and I hope to talk a bit about why medical cannabis can be a really good option for pain management for a lot of people. From a clinical perspective, I'll speak a little bit about how medical cannabis can be used safely as well. So what is the endocannabinoid system? Or as you'll often hear me refer to it during this presentation, the ECS. So the ECS is an internal system, a little bit like our cardiovascular or neurological systems. And it's built up of a few different things, some of which are internal molecules called endocannabinoids. These act on specific receptors, CB1 and CB2 receptors being some of the main ones in those. And then they're broken down by these things called enzymes, which keep the whole system in check. The point of today isn't to give a very technical talk, it's to try and give practical insight into how the system works. It is an incredibly important system. It works hand in hand with a wide range of other systems, and we'll see how that's quite important and clinically relevant as we go on. As with any system that's involved in lots of things, when something goes wrong with it, it can cause lots of different effects. And things can definitely go wrong with the endocannabinoid system. We'll hopefully talk about that a little bit. And lastly, look at how we can try and intervene to manage when things go wrong. So the ECS, or the endocannabinoid system, acts on a massive amount of our key biological functions. Many of these are involved in something called homeostasis, which is the body's way of maintaining a constant state despite external and internal stresses. This helps us manage our sleep, it helps us maintain our temperature, but it also manages lots of other things as well that possibly we don't automatically think of when we talk about homeostasis. For example, female reproduction, and that's something we'll speak about a little bit later on. I mentioned earlier on that the primary receptors within the endocannabinoid system are these things called CB1 and CB2 receptors. As we can see from this diagram, these are present throughout the body in a variety of different systems. The endocannabinoid system does not work in isolation. For example, in the central nervous system, or CNS, we see these CB1 receptors acting in the brain, which are very relevant when we look at the action of THC. More peripherally and involved in immune function and cell function, we see these things called CB2 receptors. A more primary target is possibly not the right word, but a more primary actor for CBD, and more involved in inflammation and immune function. I think we're basically done with the physiology of that now. So anyone who didn't want a biology lesson, I think we're now done with that, and we can hopefully move on. Any system that's involved in so many different functions is going to have a very large impact. And when things go wrong in that system, the dysfunction that we can see can affect a wide variety of systems and can be at play in a wide variety of conditions. Trying to understand where the problem is within our endocannabinoid system is very relevant towards targeting therapy to improve that dysfunction. Something I want to broach is this concept of endocannabinoid tone. So any system that's working within the body, be it your cardiovascular system, neurological system, or any of the hormone systems, for example, relating to thyroid hormone or cortisol, the stress hormone, are going to have a certain baseline level of tone that we want them to have. We don't want it to be too high, we don't want it to be too low. We just want it to be at the right level to allow us to get good normal function. And in the case of someone with normal endocannabinoid tone, they will have a certain level of endocannabinoid activity. Now what can happen is, for a variety of reasons, people can develop low endocannabinoid tone, and this is where there's not enough action of endocannabinoid or cannabinoid receptors in relevant tissues. And this can be clinically and directly linked to a wide range of conditions. For example, depression, anxiety, insomnia. Essentially thinking about things where you think there's a lowering of activity and there's not enough activity going on, we can often attribute that to endocannabinoid deficiency. And quite interestingly as well, this can also play a role in things we wouldn't necessarily consider, like fertility. And for the point of clarity, when we talk about anorexia, I'm using that as quite a medical term, with anorexia meaning a lack of desire to consume food, so a lack of desire to eat, not necessarily specifically relevant to anorexia nervosa. Contrary to that, our endocannabinoid system can go into overdrive, and I think this is something we see in a wider scale across the population. And this is where our body is producing too much of its endocannabinoid. The endocannabinoid system is too active. And relevant to today, there's a link between this and chronic pain, which we'll explore in a little bit more detail. But also, it's actually quite relevant in a lot of conditions that we don't necessarily think about, particularly when we talk about medical cannabis. There's been very good preclinical studies, meaning studies on animal models and looking at cells, showing how our endocannabinoid system is responsible for functions relating to the liver, the heart, our metabolism and obesity, and high blood pressure or hypertension. And it can be proposed that having dysfunction of your endocannabinoid system can play a very important role in the development of all these conditions. Before we get on to the real subject of the day, which is medical cannabis and the main reason why you're all here, I think it's important to appreciate the fact that the system that medical cannabis primarily acts on, our endocannabinoid system, is not an isolated thing. It's influenced by lots and lots of external factors, and the combination of all these interactions and influences can be called something called the endocannabidome. And this is the idea that our endocannabinoid system is being fueled not just by genetic factors, it's not just a preset thing, it's very influenced by our environment and by other factors as well. A very key one of these being our diet, as we'll talk about in a little bit more detail, but also exercise and stress, and even our gut microbiome can all influence our endocannabinoid tone. I think something to reflect on of this is when we're targeting the endocannabinoid tone or endocannabinoid system as we're speaking today, we often talk about medical cannabis, but I want to really highlight the fact that our endocannabinoid health extends beyond medical cannabis, and there are other things to consider in this as well. I said there wouldn't be any more physiology or boring science. I might have lied. There might actually be a little bit more. Omega fatty acids. So here we're talking about omega-6 and omega-3. Omega-3 is a fatty acid that's classically found in fish oil, cod liver oil, and some people might even supplement with omega-3. Omega-6 is classically found in vegetable oils. And what we have seen in the last 50 years, as we'll see shortly, is that the ratio in our diets, how much omega-6 we're getting relative to omega-3, has increased drastically. We now get a lot more of our fat from vegetable oil and a lot less from things like oily fish. And we know that these compounds, omega-6 and omega-3, fuel our endocannabinoid system. Our endocannabinoids are literally made from the derivatives of these compounds. And when you change the ratio of your diet of how much of these you're getting, it significantly impacts your endocannabinoid tone. What we can see here is a chart demonstrating the change in dietary sources of fat over time. I appreciate it's a little bit dry, but hopefully we can just take away the relevant parts from this. And what we see is that on the top graph, looking at soybeans, and on the bottom graph, canola or rapeseed oil, has had a significant increase in terms of the composition of our dietary fats, especially within the last 30 to 50 years. We can actually then correlate this to a rise in the last 50 years of something called metabolic syndrome. Now, metabolic syndrome is a technical term that's kind of an umbrella term covering obesity, high blood pressure, heart disease, diabetes, a couple of other things as well. I would propose that some people would say there's a difference between causation and correlation, right? Sometimes you have a change and it causes something, sometimes you have a change and something else happens to change at the same time. I would propose that there is more than correlation to this, and we must accept there is a degree of causation between our change in diet in the last 50 years and what we can see is an increase in metabolic syndrome. And omega-6 and omega-3 are very relevant to our endocannabinoid system. Going on to a little bit more now, looking at the clinical side of our ECS, which may be a bit more relevant. As we said, we're here to talk about chronic pain today. Our endocannabinoid system plays a massive role in chronic pain, and I'm also tying in obesity to this as well, and hopefully you'll see why in a second. There's often been an association between chronic pain and obesity. Now, this is not to say that obesity causes chronic pain, and I'm not saying that for a second. But the data does tell us that people with higher BMI are more likely to experience chronic pain. I want to phrase that in a slightly different light now, because I think that's an association that's possibly a little bit simplistic. What we know is that there is a direct link between endocannabinoid dysfunction and obesity. And we additionally know that there's a direct link between endocannabinoid dysfunction and chronic pain. So I would propose that rather than focusing on, in this particular example, obesity being a causative factor for chronic pain, I would like to think of it in a slightly bigger picture, how both of these things are related to our endocannabinoid system and a dysfunction that's existing within that. And actually, this is a very important thing to target with regards to managing both of those conditions. I spoke a little bit about metabolic syndrome already. We have very good data that shows us that our endocannabinoid system plays a very important role in the management of things like blood pressure, diabetes, and heart disease. And as we've already discussed, this is often associated with high omega-6 in Western diet. The law was very thankfully changed in this country in 2018 to allow the prescription of unlicensed cannabis-based medical products, which has been life-changing for a lot of people. I would argue none more so than the children with intractable epilepsy. We've all seen the videos of children that are having hundreds of seizures a week that are now seizure-free. As I mentioned, I'm vice chair of the MCCS. Our founder, essentially, and the lady that really made it happen for us was a lady called Hannah Deacon, who sadly passed away earlier this year. Her son, Alfie, has received treatment with medical cannabis now for over 7 years, and his quality of life has improved drastically. We can see the deficiency within the endocannabinoid system relevant to epilepsy, and we can highlight how cannabinoids, THC and CBD, are able to replace this deficiency in certain patients and improve their seizure control. Another one that I think is very relevant as well is the endocannabinoid system and mental health conditions. So, as well as acting on cannabinoid receptors, CB1 and CB2, cannabinoids also work with our serotonin system. And this can often explain to us why medical cannabis can be so good in treating mental health conditions. I'd hazard a guess that there are some people in this room that have been at some point on antidepressants, selective SSRIs, things like fluoxetine, citalopram, and sertraline. Now, these are very, very good drugs, and they work very well for a lot of people. But additionally, for an awful lot of people, they don't actually work very well. The reason that we prescribe antidepressants is they're designed to work on serotonin. Serotonin is the happy hormone, you can think of it. And the purpose of something like sertraline is to try and replace a deficiency in serotonin. Essentially, that's what it's doing anyway. However, what we would establish, and we can see this in models of depression and anxiety, is that often there is deficiency in endocannabinoid tone within these patients, and that's not something that SSRIs like sertraline is necessarily working to target. And I think this is one of the reasons why we can explain how cannabinoid treatment can be so effective for treating things like anxiety and depression. So I've talked a lot about the endocannabinoid system. I've not really talked very much about medical cannabis yet. So we'll try and move on a little bit. As we know, there are lots and lots of compounds in cannabis. I think over 150 different cannabinoids have been identified within the cannabis plant, which shows us a lot of potential for what we can do with all those different compounds. The two that have been most studied undoubtedly are THC and CBD, and we can see the wide range of effects that those can have on the body and how relevant these can be for treating different conditions. I know I'm speaking to a room full of patients. I don't need to tell you how transformative treatment with these cannabinoids and this medicine can be. But I think it's interesting to note the potential effects of the other minor cannabinoids as well, which are really not utilized in medical cannabis very much at all. It's speaking as a doctor, it's very hard to find products that actually give you the information of where these minor cannabinoids are in the products that we're prescribing. But we know they're incredibly relevant to a lot of conditions. And it'd be lovely to see a little bit more research and use of these compounds in trying to treat patients. Something that I imagine a few people will be familiar with is this concept of the entourage effect. How well can you see? Apologies if you can't see the diagram quite so well at the back. The entourage effect is essentially the idea that when you take all of the compounds within the cannabis plant, they work together in a synergistic fashion to create an overall effect. And this is one explanation for why isolate compounds, so when we take THC out, when we take CBD out, and when we synthesize it, are not as effective at treating a lot of conditions as when we use full spectrum extracts or full spectrum products. One of the things contributing to the entourage effect are these things called terpenes. These include things like limonene, which are commonly found in citrus fruits. Alongside the medical benefit of cannabinoids, we know that terpenes offer massive therapeutic potential. The effects of limonene used on its own have been shown to be antidepressant, actually anti-cancer in a lot of cell studies, gastroprotective. A lot of people use limonene for things like reflux. and quite a wide range of other functions as well. Another one is linalool, commonly found in lavender, known to be very anxiolytic or anti-anxiety. Myrcene and more sebating terpene, classically found in more traditionally indica type flowers. Caryophyllene, this comes from things like cloves. Again, a wide range of potential functions of this compound have been explored. And pinene. There are lots of other terpenes as well. These are some of the ones that have been more individually researched, but it's important to say this research is looking at these compounds on their own. We don't really have a very good understanding of how they work with cannabinoids like THC and CBD, and we definitely need some more research on that. I don't like the indica sativa terminology, and I know that's something that's shared by quite a lot of clinicians as well. I think the reason we often use it is because we don't really have anything else to use. So we're looking for something to try and guide treatment and try and, when we're asked to recommend what the most optimum treatment might be. Historically, as many of you will know, cannabis existed almost as a subspecies within itself, and the idea of having indica, sativa, and ruderalis plants. You can see a indica type plants more short and squat on the left, and a more sativa type plant on the right. But the days of landrace strains where these kind of subspecies have been grown in isolation are long gone, and essentially every product that is now available on the market is existing in some way of a combination between these different subspecies. And historically, it was associated that indica plants were more sedating, sativa plants were more stimulating. But that's not particularly to do with the phenotypic expression, by which I mean how the plants look. It's to do with the compounds that are in the plant. And I don't like, personally, the idea that I can have two products, let's say two flowers, that are both 24% THC. One of them, 80% of people might find very good for daytime use. The other one, 80% of people find very good for nighttime use. I don't like the idea that that's simply because of the genetic lineage of that plant, or how the leaves of the plant look, or how squat it is, because that isn't the case. And we know it's not to do with differences in THC content. The accepted explanation for this is to do with the minor cannabinoids and terpenes within the plant. And I would love to see a time where we can come to classifying plants based on their terpene and minor cannabinoid profiles, rather than simply if they're slightly more indica or slightly more sativa. I might not be very popular for this, which is okay. But please be nice to me if you come and find me after, and don't shout at me. In the 1970s, the average cannabis flower that was available recreationally had between 3 and 7% THC and 2 and 6% CBD. So when I did this presentation, I had a look at flowers that are available in the UK, and over 90% are THC dominant flowers, with over 40% of those containing over 25% THC. Now, one of the things that sometimes the MCCS gets a little bit of stick for is we are generally quite cautious with flowers over 25% THC. And I know some people think that's quite arbitrary. And I can agree with that to a degree. However, I think it's important to emphasize the fact that as you go up in THC, and chronic high use of THC is normally where we start seeing the negative sides of cannabis, particularly in a recreational sense. And historically, the cannabis plant wasn't designed to produce these really high quantities of THC. I am not saying for a second that there aren't patients that need cannabis flower with over 25% THC, and I accept that. I think the thing that I'm trying to emphasize from this is that actually we sometimes jump a little bit too quickly to high THC products, rather than looking at the broader spectrum of the plant as to how we can try and get good symptom control with less of this, whilst useful, also this compound that has got a degree of risk attached to it. So we've talked a little bit about the endocannabinoid system and about medical cannabis. THC, one of the main compounds in cannabis, is marvelous for pain control. It modulates the way our brain signals between neurons, and it alters how our body perceives pain. And this is very, very, very effective in something called nociplastic pain, which covers things like fibromyalgia, which is pain where we can't find the source of the pain. If you look at someone's tissues under a microscope, you can't see what's wrong, but we know the pain is there. So altering perception of pain, very, very useful for that. There have been a lot of very good studies showing that THC reduces the amount of opiates that people need to manage their pain. I very rarely speak to people that like opiate medications. I don't like them. I don't like prescribing them very much. And getting people to a point where they don't need as many opiate medications is I think, a real benefit of this marvelous compound. CBD, something that we don't really talk about anywhere near as much, but still very, very useful for pain control. It's notoriously anti-inflammatory. So for nociceptive pain, and that's pain where there is a stimuli, we can look under a microscope, we can see inflammation, we can see the source of the pain. Further research is definitely warranted on the role of CBD in that. CBD also very useful for protecting from the possible psychoactive side effects of THC, which we don't really want patients to be experiencing. When we look at the high quality studies of isolate CBD for pain control, they're generally not very convincing in terms of it being an effective painkiller. But we know what its anti-inflammatory potential is, and it certainly has a role to play in reducing opiate requirement. These are two studies that have come out within the last 2 months, both high-quality randomized controlled trials showing the benefit of cannabis therapy, in this case for back pain. These are by no means in isolation, and we have lots and lots of studies that are showing us how useful this medication can be. I think sometimes we get a bit held up in randomized control trials, and I would say from experience that NICE, who make the guidelines for doctors and for clinicians in the UK, certainly get a bit held up on randomized control trials with respect to medical cannabis. I think one of the most important things about this drug is that patients tell us it works, and it's very important that we listen when patients tell us that, even if we don't always have RCT data that shows us in a very specific patient that this is likely to work. When thousands of patients are telling you that this is a medication that's changing their life, we as clinicians have a responsibility to listen to that. Something that I don't think gets talked about enough is endometriosis full stop. Chronic pelvic pain and endometriosis are some of the most underdiagnosed conditions in the UK, and I find it absolutely alarming that it takes an average of 8 years to get a diagnosis of endometriosis, especially as it affects 1 in 10 women in our population. We know the role the endocannabinoid system plays within the female reproductive cycle, and specifically within endometriosis. And the wonderful Callie Seaman, who's here somewhere today, has co-authored this wonderful paper evaluating the use of medical cannabis for the management of endometriosis. Something we don't often think about is how different people will respond to cannabinoids and how the endocannabinoid system is different for different people. We know that the endocannabinoid system naturally fluctuates during the menstrual cycle. That's one of its roles. But that does mean that actually treatment with cannabinoids will also potentially fluctuate during the menstrual cycle. And that is something that clinicians should, I think, be a bit more aware of. We know that there is endocannabinoid dysfunction in endometriosis, which shows us that there is a target for us with regards to endometriosis, for cannabinoids to improve this very debilitating condition. A little bit, I love that picture, I think that's absolutely fantastic. A little bit about using medical cannabis safely and effectively. It's generally a very, very safe drug, but as with all drugs, there are risks, there are side effects, and these are things that we should always be aware of. A big one that doesn't get talked about enough is the interaction between cannabinoids, specifically THC and CBD, and other drugs. On this page, we've got warfarin, which is an anticoagulant. It's a very, very relevant one that interacts with THC in particular. Everolimus is an immune modulating drug, sometimes used in immunotherapy and also in immunosuppression. Valproate, phenytoin, clobazam, and carbamazepine are all used in the management of epilepsy. And it's important to note these interactions because when patients come to us as clinicians, as many of you patients will know, the private consultations in the UK are not always the highest quality. They're not always as in-depth as they possibly should be. And we don't necessarily always consider this. And it's never a patient's responsibility to know drug-drug interactions. That's the clinician's job. But I think being informed and aware that the medications you may be taking can interact with your cannabis is something that's important. As well as interactions are more to do with the levels of drugs in your blood, it's also important to remember that there are certain drugs that will work with cannabis to increase side effects. For example, cannabis used with opioids, alcohol, tricyclic antidepressants like amitriptyline, and benzodiazepines can all increase sedation, and this is something to be aware of. Something that I think is talked about a little bit less is the risk of increased heart rate and high blood pressure, and this is relevant to THC usage. Interactions with cocaine, amphetamine derivatives like methylphenidate, certain types of antidepressant like venlafaxine, and pure amphetamines can significantly increase this risk, and this is one of the reasons why cannabis use alongside illicit or unorthodox drugs is quite heavily frowned upon and shouldn't be done. As you can see, there are quite a few other drugs there, and I would wager a bet that there are a few people in here that probably take some of these drugs. This isn't to say that it's dangerous to take these drugs with cannabis, but it's something to be aware of. And a key thing I'd like to highlight from this is if you have any changes in your medication, please make sure you tell your cannabis clinician at your next appointment and let the clinic know that you've had some changes to your medication. Something else that can interact with cannabinoids is smoking. So smoking tobacco actually alters the way your liver metabolizes cannabinoids and lots of other drugs as well. And something we always tell people that are on warfarin therapy for blood thinning is that you should never suddenly stop smoking because it can make the warfarin act much more rapidly. The same applies to cannabinoids as well. If you're